Hello, everyone. Good afternoon. Dear esteemed veterinarians, a very warm welcome to today's session on radiographic evaluation of abdominal organs in small animals. We are honored to have with us our distinguished speaker, Dr. Arun Anand, whose insights continue to guide us and inspire the veterinary fraternity. I'm Dr. Vishal Sharma, a proud veterinarian and managing director of Oriheal Lifesciences. As a practicing veterinarian myself, managing two pet hospitals in North Delhi under the name Pets Planet India Pet Hospitals Private Limited, I truly understand the ground level challenges, hopes, and responsibilities we all carry. Buy a vet for the vet, a mission is very close to my heart. It gives me immense pride to share that Oriheal Lifesciences has grown into one of India's leading manufacturers of veterinary pharmaceuticals with a robust product profile of 180 plus products. But beyond numbers, we are truly defines us is our purpose. We are a company built by a vet and exclusively to serve vets. Everything we do, be it innovation, education, or support, it's centered around empowering our veterinary community. We are here with safe, trusted, and first in India veterinary solutions. Our product portfolio includes herbal medicines, India's first 100% safe, sugar-free, and side effect-free formulations, safe even for newborn pups and kittens. Nutraceuticals, pharmaceuticals, injections, and grooming solutions, all carefully formulated for better compliances and outcome. Breakthrough formulations include alprazolam suspension, tramadol suspensions, furosemide suspension, metazapine suspensions, bidophorol tartrate injection in 10 ml, furosemide injection in 30 ml. Presentation and cost effectiveness considering. A robust range of neurocardiac ophthalmic dermatology products tailored for small animal needs. Strengthening veterinary knowledge across India. Under our initiative Buy a Vet for the Vets, we have created one of the largest platforms for continuous veterinary education through regular webinars. We aim to spotlight advanced yet often unexplored topics like feline medicine, cardiology, neurology, radiology, ophthalmology, and many more. Because knowledge remains our most powerful tool in saving lives. Your support is lifeline for us. Friends, this journey is only possible because of your unwavering support. Every step we take forward, every educational effort, every new product is fueled by your belief in us. We humbly request you to support this mission in whichever way you can. Even a small order, a word of encouragement, or referring us to a fellow vet, each gesture keeps this mission alive. Ordering with us is quick and effortless. Just call or text us on the number mentioned in the chat box. Our team will personally connect with you to take your order. We deliver directly to your clinic. All benefits and supports go directly to you, and we promise highest trade margins to the vets. Let's walk this path together to grow, to learn, and to raise the standards of veterinary care across the India. Thank you for being with us today and for being a part of this journey. Thank you so much. And here I would like to say a few words about our esteemed speaker, Dr. Arun Anand. Dr. Arun Anand completed his graduation and post-graduation from Punjab Agriculture University, Ludhiana. He acquired doctoral degree from Guru Angad Dev Veterinary and Animal Sciences University, Gadwasu, Ludhiana, a renowned veterinary college of North India, and entire India is fan about this university and Professor Arun Anand. He joined as assistant professor in the Department of Surgery and Radiology, Punjab Agriculture University, and rose to the position of professor and head Department of Veterinary Surgery in Gadwasu. He acquired certificate of qualification from Canadian Veterinary Medical Association. He also cleared Education Commission for Foreign Veterinary Graduates ECFVZ program USA and registered as DVM with Michigan State Board of Veterinary Medicine USA. His main field of work are in urogenital surgery, joint surgery, oral surgery, especially small animal endodontics, emergency surgical procedures, soft tissue surgery, and small animal radiography. Let's welcome Dr. Arun Anand. Thank you, sir. Thank you for being with us, sir, today.
Thank you, Dr. Vishal. for this presentation so that I can interact with all my fellow vets all out India, and I want to discuss few practical points which I will be telling you in next approximately in 2 hours.
Yes,
So should I start with my?
sure, sir. Sure,
Yeah.
sir. Sure, sir. We
Okay.
are eagerly waiting for that, sir.
Okay.
Full speed.
So yes, I welcome all my fellow vets from all over India who have joined me to listen my webinar on radiographic evaluation of abdominal organs in small animals. So this webinar is in continuation to the previous webinar which I delivered last month, in which I discussed about the gastrointestinal this radiography as well. So so now in this webinar I'll be telling you about the radiography of all other organs except GIT. So if you have attended or if you have listened on YouTube by webinar, you might be knowing that that in GIT, a whole of the GIT is a hollow organ, and most of the anomalies, most of the affections of the GIT can be easily diagnosed by using radiography or contrast radiography as well. But one thing is that no doubt that ultrasonography is there. There is a number of advancement is there now in our field for better diagnosis. But there is one thing I must tell you: there is no alternative to radiography. Yes, it's the oldest method of diagnostic aid, but still it's a very valid, and it can tell you a lot of things which other diagnostic aid may not able to tell you. And it's a cost effective as well, and it is easily available. Most part of the country they have means even in a remote areas we have a human radiography unit which can their services can be used for pets as well, and they are happy to to share their facility for the pets as well. Another thing is although ultrasonography is taking over the these radiography, especially in the abdomen, but they are complement. One thing I must tell you, they always complement to each other. Another thing is whenever we want to go for radiography or ultrasonography, so both should be done simultaneously. So one diagnostic aid may not be able to bring you a final diagnosis, but I'll be telling you few points in this webinar in which the abdominal organs affection will be discussed in detail. So let's start with the webinar. So regarding the abdominal organs, one thing is another term which is another term. This is the mass effect. This because I told you that that GIT is a hollow organ, but all the other organs they are except urinary bladder. All other organs they are basically soft tissue organs. So they will not look like they will almost look like the same. Like liver and spleen, radio density will be the same. Means let me tell you that I'll be using a few terms: radio density, radio opacity, radiolucency. So it means these indicates about how in the X-ray that particular structure look like. Radio opaque means the structure will be more white in the X-ray. Radiolucency means it will be gray or dark in color. So if you talk in terms of the abdominal organs, the liver and spleen, and even kidneys, they look like the same. This is called the mass effect. So although there is abdominal fat is there, so which will help us to distinguish these organs in radiograph. More the fat is there in the abdomen, better the radio density is there, better the radio contrast is there. So that's why obese animal they have good abdominal radiograph rather than the cactic or obese or hidebound condition or weak animals. Similarly, the animals which are older, their radio density their contrast is much better as compared to the puppies which have minimum fat in them. So this is called mass effect because of the radio density, similar radio density. So means abdominal masses, they often cause displacement of the other organs. Another thing is whenever, because it's a big barrel shaped cavity. Abdomen is a barrel shaped big cavity. So there the number of organs are placed. So whenever these organs they enlarge, they always try to push the organs away from its place. So this is called a mass effect. So which organ is being pushed away from its normal place? So that usually help us to diagnose the origin of the mass, origin of the disease as well. Must tell you. So masses they typically they grow spherically. They will spherically outward. Just for example, liver. So liver is in approximation with the diaphragm cranially, and caudally it is in a relation with the abdomen, with the stomach, with the duodenum, and small intestines as well. So whenever there is enlargement of the liver is there, so these structure, because cranially there is a diaphragm, hardly the liver can't go cranially because it is a thoracic cavity is there and a very tough structure diaphragm is there. So that's why it will try to grow caudally and it will try to push the organs to away from its normal place. So this is that's why we call it as that normally these abdominal organs they grow spherically. So now comes to the aim of my presentation. So I'll be discussing in detail about the radiographic anatomy of the abdominal organs in small animals first, then followed by I'll be telling you about the radiographic interpretation of the cranial abdominal organs pathology. Cranial abdominal means I'll be telling you about the liver pathologies, I'll be telling you about the spleen pathology, I'll be telling you about the pancreas pathology as well. Now in third part of my webinar, so I'll be telling you about the how to diagnose with the help of X-rays about the urogenital diseases, about the kidneys, about the urinary bladder, about the prostate, about the uterus. So all these things will be covered in my third part of my webinar. So if let's come to the normal structure. If you see that there is a picture is there in front of you, and this picture is when you look the abdomen from its ventral aspect, from its ventral aspect. So when you look the abdomen from the ventral aspect, the structure, these structures will be in front of you. The first structure, liver is there. The liver, you can see liver is just in approximation or in relation with the diaphragm. So blue structure which I highlighted, it's all liver, and you can see that most part of the liver is towards on the right side. Some part of has gone from medial towards the left side, but the left part of the liver never touches the left side of the abdominal cavity, abdominal wall, I should say. But most of that is present in the. So, this you can see the white line which I highlighted. This is the stomach. You can see stomach is just in approximation, in relation with the liver. So if you see this one, this yellow structure which I highlighted, this is the pylorus. This is the pylorus of the stomach. So pylorus that is fully in contact with the caudal aspect or caudal margin of the liver. So whenever there is a liver enlargement is there, this pylorus will be pushed caudally. So position of like looking for the position of the pylorus in the radiograph, that can help you to diagnose whether there is enlargement of liver or any other structure is there. So now, in further slides, I'll be telling you how to see the pylorus. And now this portion, the red portion, this is the body of the stomach, and fundus and the body of the stomach. So body and the fundus of the stomach, especially the body, is not in contact with the liver mostly. So it will be pushed only if the left part of the liver will be enlarged. Okay, so if there is a generalized hepatomegaly is there, means liver, whole of the liver is enlarged, then chances are there that pylorus will be pushed, but the body and the fundus that will remain within the rib cage. I'm talking about the rib cage, so I'll be showing you those things as well. So another structure which is in fluorescent color, this is a spleen. Spleen is an attachment, spleen that attaches with the greater curvature of the stomach. There is a gastrosplenic ligament is there, so which hold both the structures together, and is mostly in like whole of the spleen that extends along the greater curvature, and the tail of the spleen that goes up to the ventral part of the abdomen as well. So this one. So this is a yellow one. This is a yellow structure which I highlighted. This is the duodenum. This is the proximal duodenum. If you see, the cranial part of the proximal duodenum is in contact with the caudal aspect of the liver. So this is another structure which you have to watch if you want to diagnose, or if you want to look, or if you want to differentially diagnose the hepatomegaly, then you have to look for the duodenum as well, because duodenum is also in a close approximation with the liver as well. So all these things I'll be discussing in the X-ray as well. But my idea of telling you about the anatomy is that to create a picture in your mind that what will happen if a particular organ is enlarged. Then there is this one, this black one. This is the pancreas. This is the pancreas. You can see the pancreas which is placed on the medial aspect of the duodenum. So this is another important structure, because like if there is a pancreatitis is there or pancreatic mass is there, then we have to look at this point and how to diagnose. So I'll be telling you about the later on as well. Now, another important structure which I highlighted just now is the white line, between the white line. This is the colon. Colon means it's ascending colon, transverse colon, and descending colon. Three parts there. So whenever there is enlargement of the cranial part of the abdominal organs, so this structure will also be pushed caudally. So if you see the transverse colon and the descending part of the colon is pushed caudally, it means chances are there that either the stomach is involved, or the gastric carcinoma is there, or spleen is enlarged, or there is some pathology is there in the spleen, so which has led to its splenomegaly and has pushed the transverse colon and the descending colon caudally. Similarly, if you go to the ascending colon on your right means animal's right side, so if ascending colon is pushed backward, it means the liver, ultimately the right part of the liver, right lobe, means if you see like anatomically, you must be knowing there are 5 lobes are there. So right, the caudate lobe is the outermost part on the right side, then the right lateral, right medial, quadrate, left medial, and left lateral. Okay, so if there is a right lobes of the liver is enlarged, then ultimately it is going to push the ascending colon as well as the transverse colon as well. Means it will not displace the descending colon. So from these points, you can easily diagnose that which side of the liver is enlarged, or which spleen is enlarged. Then it means the descending colon will be pushed downward, caudally, I should say. Then you can see ascending colon, then transverse colon, and the descending colon. Means just looking into the soft tissue density or any enlarged organ inside the abdomen may not serve the purpose until unless you look into the topography or anatomy where the other organs, surrounding organs are placed. So in the report, it's very important whenever you write a report of a radiograph, you should write about the position of other organs, whether they are normally placed or they are displaced from away from the. So another thing which I want to tell you, that most of the organs in the abdominal cavity, except duodenum, descending colon, so most of the organs, they are quite mobile in nature, so they can easily be displaced as well. So that's why this is anatomy wise, it's a very important. You should know which structure is placed in which place. So here you see the black line. This is called costal arch. This is the limit of the rib cage. It means you can see from this black line that whole of the pylorus, most part of the stomach, and whole of the liver, this is present within the rib cage. If there is any alteration is there, then the stomach, if the stomach comes out of the liver, if the rib cage, it means we have to see that why it has come out, why it is placed out of the rib cage. So let me go to the next slide. So this is the lateral view, that was the video when you look into, this is topography of abdominal organ. A topography of abdominal organ when you view the animal from your left side. So this is, you can see liver. Liver is in approximation cranially, it is in relation with or approximation with the diaphragm, and caudally you can see it is in approximation with the stomach. So, and then there is a spleen is there. So spleen, this is spleen. Spleen is you can see it is attached with the stomach on its greater curvature, and on there is one circle is there, that yellow circle that indicates the tip of the spleen. So tip of the spleen will be present near the ventral abdominal wall, but the body and the head of the spleen that will be in contact with the stomach. So that's why what happens if there is a splenomegaly is there, then, or if there is a splenomegaly and the lesion is in the tail, so you can see the tail is just near the small intestines. So that's why whenever there is a lesion in the tail is there, then the small intestine will be displaced dorsally. But if there is a lesion is there in the head and the body of the spleen, then most likely it will be that small intestine will be pushed caudally and the stomach will be pushed cranially. So this is how like you should see inside the abdominis. Another thing is like initially, because we are looking into the x-ray for so many years, then we can easily in the plain survey radiograph we can see where is the stomach. But initially if you have a difficulty in looking into the stomach, where is the stomach is there, then you can, if there is organomegaly and you want to see the stomach position, then you can go for contrast radiography simultaneously as well. You can give barium sulfate and look into the stomach, whether the stomach is where it is placed, within the rib cage, inside the rib cage, or where is the pylorus is placed. So everything will be clear with the contrast radiography as well. So, means survey radiography for organomegaly, contrast radiography to look into the position of the intestines at the as well as the stomach. So these two things, they can help you to add up in your diagnosis as well. So this is a left kidney. Left kidney is usually like left kidney is free and is always in contact with the spleen. So right kidney is fixed in position as in and is in contact with the liver and it's in fixed in position. But the left kidney is always free in position and it can move anywhere. But right kidney will only move when there is a hepatomegaly is there. It is not going to move with the enlargement of any other organ. So this is another practical event which I want to tell you. So if you look into this is topography of the abdominal organs when you view from the right side. If you see from the right side, so right side means on your right side will be the head and your left side will be the tail of the animal. So if you see here is the liver and here you see the right kidney. So right kidney, and if you see from the right side, you can't see the spleen. So this is very important point. So you can't see the spleen. So that's why in radiograph as well, if you want to look into the spleen, you should go for right lateral recumbency. In left lateral recumbency, sometime or most of the time, you can miss or you will not able to see the spleen. So that's why like, so there are few views are there which are very important. If you want to look into the spleen, you should go for right lateral recumbency, right lateral view as well. So another point, important point, which I want to highlight that single view, I again and again in all webinars, I am stressing that single view for a particular organ may lead to misdiagnosis. So that's why already you should go for two views, orthogonal views, 90-degree, lateral, ventrodorsal, anterior, posterior. So lateral view, this is survey radiograph. You can see, if you see, this is the liver, L is liver, this is stomach, this is the body, body as well as the cardia and body of the stomach, ST. Then this is right kidney and left kidneys. Then urinary bladder, UB, and descending colon is C, and small intestines will be visible in the mid-abdominal region, and cecum will be visible as a comma-shaped structure at this point, you can see. So spleen is at this point like in the ventral part of this is the tail of the spleen, which I already discussed about and I even told you about the topography as well. And this is a pylorus. So I told you that whole of the pylorus is in contact with the liver, but cardia and the cardia as well as the body of the stomach is most of the stomach, their part is not in contact with the liver. So let's come to the VD view where what you have to anatomically what you have to do, see in a VD view, ventrodorsal view. So this L is the liver, stomach is there as T, cecum is on the right side. This is comma shaped structure. Cecum is there. Small intestine will be visible all over in the middle abdomen region. Then cecum is this colon is the C is the colon. Then spleen will be visible at this point on the left side. In ventrodorsal view, spleen will be visible, which is directly in contact with the stomach. You can see greater curvature of the stomach is in contact with the spleen because they are attached with the gastrosplenic ligament. Then this is the left kidney. You can clearly see the left kidney, and this is about the survey radiograph, different structures, different normal structures. You can look into the X-rays. Now comes to the next. My point is that why there is a need to take an X-ray, abdominal X-rays, indications. So if there is a vomiting, chronic vomiting is there, or there is a history that animal has ingested a foreign body, or there is no history at all, but there is no history that sometime animal eats some foreign body, and there is no history. Animal owner doesn't know. If there is a vomiting is there, then abdominal pain is there, then hematuria is there, pain on defecation is there, then abdominal masses you suspect, or there is a belly enlargement is there, means pendulous abdomen is there. Then these are the indications you must go for an X-rays as well, surviving. And even additionally, if you want to go for a pregnancy diagnosis, or if you want to go for any other suspicion that it can be a GIT problem or other abdominal organs, you should go for an X-ray, and it's a very handy diagnostic tool, as I already discussed about it. Patient preparation for abdominal radiography is very important. One thing I must tell you that 20 to 25% of misdiagnosis is more normally because the patient preparation is not proper before taking abdominal radiography. So this is a very important point which I want to discuss right now, means at least 12-hour fasting. If it's an elective radiography, in emergency radiography is hit by a car, or if animal has injured, you want to go for to look into the lungs or anything. So then it's definitely you have to go for a radiography immediately. But if it's an elective procedure or elective radiography, or animal is suffering chronically having a problem, then 12-hour fasting is very important. Then cleansing anemia before radiography, that can add up in your diagnosis. So let the animal express its urinary bladder. This is also very important. And if you want to look into the caudal part of the abdomen, then you must catheterize. You must evacuate the urinary bladder before taking an X-rays. So history and physical examination findings must be considered. So what is the history? So different questions you have to ask. Physical examination findings are must be considered before patient. Must decide the applicability of particular procedure. Means you want to take a survey radiography or contrast radiographic procedures has to be done. In contrast radiographies, most of the time is more diagnostic in GIT problems, but in other abdominal organs like IVP, intravenous pyelography, or contrast radiography of the urinary system can be done. But for other organs, contrast radiography is not as diagnostic like as in GIT. Now see the X-ray, like you can see this is full with the food, and there is a lot of urine is there in the urinary bladder. So radiography is full with the stomach, urinary bladder. This can lead to the summation effect. Means you can't see the other organs, you can't see the kidneys, you can't see the spleen. It means all the small intestines, they are squished up inside. Means like cranially it is being pushed by the full stomach, caudally it is pushed by the full urinary bladder. So that's why it will lead to the summation effect. So that can lead to the result of the misdiagnosis. So the same dog, when it was fasted and was radiographed next day, you can see clearly, we can see the different part of the abdominal organs as well. Stomach can be visible, liver, small intestine, urinary bladder, or kidneys. So all these means this is a preparation, animal preparation before radiography is another very important diagnostic point as well. So if sometimes what happens, sometimes the owner, they usually come from like quite a far away place. So what you can do, you can call them again back after one next day, and after like proper fasting and radiograph with the proper anemia as well, so that you can go for a proper view of the X-rays. Now, abdominal imaging techniques, VD and lateral, everybody knows. Positioning has to be done whenever you look for abdominal radiograph with abdomen. So in abdominal radiograph, the diaphragm and the pelvic inlet should be clearly visible. Femur should be placed perpendicular to the spine. So hind legs should be pulled forward or backward as per the organ requirement. What if you want to look into the urinary bladder and the prostate, then the legs should be pulled backward. But if you want to look for the caudal part of the urethra, then the legs should be pulled forward. So accordingly, you can adjust as well at the time of taking X-rays. So exposure is made at the time of expiration. This is exactly opposite to the thoracic radiography. In thoracic radiography, we prefer inspiration at the time of inspiration exposure to be done, but in abdomen exposure is to be done at the time of expiration. So collimation is very important. So collimation has to be done. So what I teach to the students, that whenever you need to go collimate for abdomen, you should go the collimation, the cranial boundary should be up to the level of the caudal part of the scapula, and the caudal border of the collimation should be up to the anal region, anus region, or the base of the tail. So this should be the collimation should be done. So this will help you to decrease the scattering as well. So what you have to, whenever you visualize the peritoneal, means I told you that there is a mass effect is there. Almost all the abdominal organs, they look like the same in the radiograph, but because of the presence of the fat, we are able to distinguish the margins of the abdominal organs are there. So more the fat is there, the better visibility, better contrast of the X-ray will be there. But sometimes there is a loss of visualization, means serosal detail is lost when the young animals, emaciated animals, or there is a peritoneal effusions are there, or there is intra-abdominal mass are there, especially liver enlargement, kidney enlargement, or spleen enlargement is there. Then sometimes the serosal detail. Serosal detail means, whenever I use the term serosal detail, means outer margins of that particular organs, serosal detail, that will be lost in these three conditions at least. So structures which we can normally see in an X-ray, liver can be easily seen, spleen can be easily seen, kidneys can be seen, stomach can be easily seen, duodenum, and then small intestines, and cecum can be seen, colon, bladder, prostate. So retroperitoneal fat. Retroperitoneal fat means fat which is around the kidneys. So these are the organs can be normally seen in an X-ray. If proper exposure is done, proper contrast is there, then these organs can easily be seen in X-rays. But there are few structures are there which we can't see in an X-ray, like gallbladder, like pancreas, adrenals, ovaries, uterus, ureters, lymph nodes, mesentery. Means these organs, they can't be seen in a normal animal. But if there is an abnormality is there, if there is a pancreatitis there, or pancreatic tumor is there, or if there is a pyometra is there, or there is some stone in the ureter is there, or lymphadenopathy is there, mesenteric lymphadenopathy is there, then we can easily see these organs in the survey. Otherwise, if these structures are normal, it means then those structures will not be visible in a normal survey radiograph. Even vasculatures are not visible. So let's come to the first organ, liver. So this is a master organ. It has a very important role inside the body. It does a lot of things, hormones, detoxification, glucose metabolism. Then there's a lot of things that it does, and even in digestion as well. So normal size means margin of the liver often they are not well visualized, and its size can be indicated by the adjacent. If you recall my anatomy first slide, you see I told you that the liver right kidney is in close approximation with the liver, and stomach, not all part of the stomach, but pylorus and some part of the body, I should say, they are in contact with the liver, in the caudal margin of the liver. So these are the margins. So position of these organs can also tell us about the margin of the liver as well. But if you look into the X-rays, radiographic interpretation regarding the liver should be done as per the position of the adjacent organs. So normal liver that remains inside the costal arch, means it's main inside the rib cage. And if it is altered, it's a generalized hepatomegaly is there, or focal hepatomegaly, means one part of the liver is only enlarged, or there is a whole of the liver is enlarged. So that part of the liver might come out of, depending upon how much enlarged it is, it can come out of the rib cage as well. So when if the liver is generalized enlarged and hepatomegaly is severe hepatomegaly is there, then most of the organ it will push out of the rib cage as well, stomach, right kidney, so and even duodenum, so it'll push out of the rib cage. So radiopacity is a homogeneous soft tissue opacity. Almost all the organs except urinary bladder, they have a homogeneous soft tissue opacity, where the ventral margins should appear as sharp. I'll show you as they should be sharp. And evaluation of liver size that requires the evaluation of the liver borders and the position of the adjacent. Already I discussed in the previous slides as well. Means this is how the normal liver should look like. If you look into, let's see in the ventrodorsal. Let's start with the ventrodorsal in a normal. So if you see the liver, this is the stomach. This is the stomach. You can see the whole of the stomach is within the rib cage, and this is the caudal margin. This is the caudal margin. The cranial this caudal margin, so the caudal margin of the liver is in contact with the lesser curvature of the stomach, with the lesser curvature. And if you see, this is the red line which I drew. This is the cranial margin. This is in contact with the diaphragm. So okay, so lateral lobe is usually near the abdominal wall. Near the abdominal means I'm talking about the right lobes, right lateral lobes especially. And if you see, this is the limit of the costal arch, limit of the rib cage is there. You can see both the structures are inside, and I can see even the duodenum is there, and even the colon, the transverse colon is there. So let's see, just if you see into this diagram, you can see the liver. Here, this one, the blue structure, this is the liver, normal liver. And if you see, fundus is there, pylorus, and this one, fundus and pylorus. You can see fundus of the stomach is not in contact with the liver, and pylorus is there. And if there is a hepatomegaly is there, just for example, this new blue structure is the hepatomegaly. If you see, this is the hepatomegaly. In hepatomegaly, what will happen? The pylorus which was present at its normal position, it will be pushed outward. You can see, and the pylorus will be pushed chordodorsally. So if you see, the liver has 5 big lobes and 1 small cord lobes. So I told you that part of the right middle quadrate and then left medial, these are the 3 lobes. They are in contact with the pylorus. So that's why whenever there is a focal hepatomegaly is there, and that involves these 3 lobes, any one of the three lobes, it will push the pylorus out of the rib cage. So this is the focal. This will help you to diagnose the focal hepatomegaly, that when only a part of the liver is enlarged. But when there is a generalized hepatomegaly is there and severe hepatomegaly is there, then even the fundus and the body as well as the pylorus will be pushed. So you can see the position of the stomach that can help us to diagnose whether it's a generalized hepatomegaly or it's a focal hepatomegaly involving only a part of the lobe of the liver. So this is a normal one. So let me tell you about this. And means assessment of the liver, means assessment of the liver size in a lateral view. You can see in lateral view, the caudoventral margin of the liver is located at or minimally caudal to the last. I'm talking about this portion. I'm talking about this portion, the white circle. If you see, this is the caudoventral margin of the liver, and you can see it's just outside or within the rib cage, just outside the rib cage. This is the normal one. And so you can see all this, the red outline, this is the normal size of the liver. And if you see the gastric axis, this is another term which I'll be discussing, the gastric axis. This is another thing which you look into the X-ray when you look for the liver. So here, this is the stomach. If you see, this is the stomach. The yellow, you can see oval structure is the stomach, and the upper one is the body and the fundus. The lower one is the pylorus. So if you see, if you draw a line in the middle of this stomach, in the stomach, you can see this line. This is called gastric axis. This is called gastric axis in a lateral view. And you see this gastric axis is almost parallel to the ribs. And in a normal animal, it should run parallel to the ribs as well, and as well as perpendicular to the spine. You can see it's almost perpendicular to the spine and it's parallel to the ribs. So this is called gastric axis. When you draw a line uniting the body with the pylorus, with the fundus and the body, pylorus, then it is called a gastric axis. So looking for the gastric axis is very diagnostic point. If there is a variation in the gastric axis, not parallel to the ribs, or is oblique and is caudally placed, it means there is enlargement is there in the liver. Hepatomegaly is there. So here, if you see, this is the liver. If you see the liver, and this is the gastric axis. So if you see the gastric axis there, so this gastric axis in a VD view will be perpendicular to the axis of the spine. Same way in the lateral view, as I told you, it is perpendicular to the spine. Same way in the VD view as well. So this gastric axis will be. So the caudal margin of the liver are difficult to diagnose or visualize in this view. This is very important. If you want to look for the margins in VD view, you may not able to. But in lateral view, if you want to look at the margin, then you can see. Why? Because of the presence of the falciform fat. The falciform fat is present on the ventral side of the falciform fat is present on the ventral side of the liver. So that fat makes a very good contrast, and it is clearly, margins are clearly visible. So that fat is not so prominently visible in VD view. So that's why the caudal margins are not so visible. So duodenum, you can see, let me highlight the duodenum. If you see, this is the duodenum. I repeatedly, I'm going to highlight. You see, this is the duodenum, and on the duodenum is on the right side. So duodenum is in contact with the right side of the lobe, and this is the stomach. And here is the one angle, which is, you have to see this angle as well. This is called gastroduodenal angle. So because nowadays DR X-rays are available, even CR X-rays are visible, very good contrast is there. So you can easily see this gastroduodenal angle. Let me again repeat, because it is very important point whenever you look for pancreatitis or any anomaly for pancreas. So if you see, look into this one, this is the duodenum, which is present just medial to the lateral wall, right lateral wall. Okay, so you can see here it is this stomach. So this angle, black color angle, this is the gastroduodenal angle, and it should be acute angle. It should not be obtuse or more than that, means then there is some problem with the pancreatitis, or so I'll be showing you the X-ray, those X-rays as well. So shape and margination best visualized when because of the falciform fat. So normally it's a sharp, but normally these angles, you see that this small X-ray, normally it should be very sharp. So sharp margin should be there. But if there is a rounding of the edges are there, and slightly it is away from out of the rib cage or costal arch, then it means there is some infiltrative disease is there, or there is some systemic congestion because of the heart failure. Because of the heart failure or because of any other region, there is systemic congestion. Heart failure is the one of the common cause for hepatomegaly, and that leads to the rounding of the margins. So you can see the second picture, diffuse infiltrate, and if you see there is irregular margins are there. If you see there is irregular margins, it means there is some cirrhosis or intrahepatic masses are there. There is some tumor is developing, or there is some abscess is there, cirrhosis is there. So these means even the margins, looking for the margin. Whenever you look for an X-ray in a survey radiograph, you should look about the margins of particular organs, then about the placement of other adjoining organs, then what is the shape of the margin, whether it's a sharp or it's a slightly oval in shape, or it's irregular in shape. So these will tell you a lot of things about the disease process. So let's come to the liver enlargement. So liver enlargement, I'll be discussing in basically two parts. One is generalized, when whole of the liver is enlarged, or focal hepatomegaly is there, when a part of the liver is enlarged. So whenever there is a liver enlargement, you see this is the pictorial diagram. So let's see generalized. Generalized means whole of the liver will be enlarged, then it will displace the stomach, especially the pylorus, and towards caudally as well as dorsally and to the left. Previously webinar, I told you that pylorus is present on the right side of the midline. Whole of the stomach will be present, other part of the stomach, body and the fundus of the stomach will be present on the left side of the midline. But whenever there is generalized hepatomegaly is there, then pylorus will be also shift towards the left side, towards the body and the fundus. And it will be pushed caudally as well. So alteration of the gastric axis, I told you the gastric axis, it will be altered and it can go oblique rather than parallel to the ribs. It will be obliquely placed, or it will be away from its axis. So gastric axis will be obliquely and no more parallel to the ribs. This is also very important, gastric axis. So I always recommend, I always tell that whenever you write a report, write about these things in the report as well. Adjoining organs, gastric axis, try to use these terms in reporting. So this will look more professional when you look into write for these X-ray reports. So right kidney will be displaced caudally. I told you that right kidney is in a fixed position, and there is a renal fossa is there inside. There is a structure, renal fossa, in which the right kidney is attached, and whenever the liver generalized hepatomegaly is there, almost 90% of the right kidney is within the rib cage. But when there is a generalized hepatomegaly, even the right kidney will be displaced caudally, and most part of it can, depending upon how much big the liver is, it can go out of the rib cage as well. So extension of the liver beyond the, you can see here, you see this X-ray hepatomegaly. If you see the caudoventral margins, looking into the caudoventral margins, you can see I'm talking about this one. I'm talking about this caudoventral margins. So if you see the rib cage, so rib cage, it is quite away from out of the rib cage as well. So liver margins are rounded in shape. So liver margins, pylorus is displaced. If you see where is the pylorus, if you see this one, this is the hepatomegaly, the whole of the liver, and this is the pylorus, and upper one is the fundus. So you can see, you know, you can easily see. And if you have in this patient, if you have a hard time in recognizing where is the pylorus, then simultaneously you can go for barium swallow as well. Then barium swallow, take an X-ray after 1 minute, then the pylorus will be highlighted. See the pylorus, whether it's within the rib cage or out of the rib cage, what is the gastric axis, then it will help you in diagnosis that which part of which side of the liver is enlarged. Okay, so if you see the right kidney, this is the right kidney. So right kidney, you can see the right kidney is also pushed out of the rib cage as well. It means whole of the liver is enlarged. Hepatomegaly, this is the right kidney as well. So this is the costal arch, limit of the rib cage. You can see I should say 75% of the stomach and is out of the rib cage. Whole of the right kidney is out of rib cage, and most of the liver is also out of the rib cage as well. So here you see, that this is the limit, and here you see the stomach. This is the stomach. So pylorus is out of the rib cage, and this is another case. This is another case. You can easily, I already outlined the enlarged liver as well. So you can see how big the liver is. Another important point which I want to tell you right now means in the liver, whenever there's a hepatomegaly is there, then the small intestine will be pushed caudally, but the small intestine remains in contact with the ventral abdominal wall. But if there is a splenomegaly is there, then the small intestine will be pushed dorsally. And small intestines will not be visible. I'll be showing the X-ray in next slides as well, how the splenomegaly will look. But here you should have a picture in your mind, because I'll be discussing about this slide later on as well. You can see small intestines are pushed caudally, but they still remain in contact with the ventral abdominal wall. This is a diagnostic or differential point if you want to differentiate whether this is a splenomegaly or it's a hepatomegaly. So you see, even here you see that in the ventral side, you can see the whole of the liver, and even whole, this is the rib cage, limit of the rib cage, you can see whole of the stomach is out of. It means left side, right side, central portion, caudate, all 5 lobes are enlarged, and it is pushed outward. In stomach has been pushed outward. Whole of the stomach is pushed out. If it is a focal, then let's say. So now if there is a hepatomegaly, hepatomegaly is there. Another second point. First of all, first point was we have to look for other organs, how the other organs are placed, stomach and the right kidney is placed. But now you have to look for the margins, whether the margins are smooth, like this one, these margins I'm talking about. Although like this is also hepatomegaly because this portion of the liver is out of rib cage. But if you see the margins are smooth. When the margins are smooth, it means it is not because of any tumorous in origin. It can be because of some inflammation, or it can be because of some inflammatory in origin, means any ehrlichiosis can also lead to these ones. Let me tell you about this. Is Cushing disease can also lead to these hepatomegaly with smooth margins. Cushing means when there is hyperadrenocorticism is there, means the body is creating a lot of cortisol or corticosteroids or hormones from the adrenal hormones, so that led to the increase. So, and steroid hepatopathy means if animal is on steroid therapy, that can also lead to this hepatomegaly, but margins will be smooth. And diabetes as well, if there is increased sugar level or glucose level is high, then can also lead to hepatomegaly with smooth margin, hepatic lipidosis, heart failure, which I told you in my first webinar as well, that whenever there is a heart failure, especially the right side heart failure, that leads to venous congestion. When there is a venous congestion, that leads to hepatomegaly, and that hepatomegaly will have a smooth margins. So even lymphosarcoma sometimes, especially in the cats, lymphosarcoma, that can also, depending upon the stage, it can have a smooth margins as well. Inflammation, or there is cholestasis is there, that can also lead to, means you have to look for the margins as well. But if you look into this x-rays, this is not a smooth margins. These are the lumpy margins. These are not smooth margins. Means looking for the margins is very important. Like no doubt the importance is also hepatomegaly, but looking for the margins can also be, means generalized hepatomargins, generalized enlargement hepatomegaly with lumpy margins can be because of the malignant neoplasia, nodular hyperplasia, or focal enlargement is because of neoplasia, that, and even cyst and abscess or hyperplasia that can lead to the lumpy margins. Even I should say the cirrhosis is there. If there is cirrhosis, no doubt in cirrhosis the liver size will decrease, but the margins will be lumpy, will not be regular, will not be sharp. Okay, so you can see the stomach as well. If you see the stomach, see the gastric axis, it's all altered. So you can see the gastric, if you join and the body as well as the pylorus, it is no longer parallel to the ribs. So you can see the stomach is pushed upward, outward. Focal. So as I discussed in that focal means it can be generalized hepatomegaly or a part of the liver. Part of the liver is enlarged. So either it can be right part of the liver is enlarged, or the left part of the liver is enlarged, or it can be the middle part of the liver is enlarged. So you can see whenever the right side hepatomegaly is there, focal hepatomegaly is there, then I told you that the right part of the liver is in contact with the pylorus and the descending duodenum. So you have to look for these structures. But if there is a left side enlargement is there, so if there is an alteration in the place of the spleen and the small intestine, so then you can see, let me show you the x-rays and then you will understand these things very clearly. So differential means if there is a focal hepatic masses are there, then the neoplasia, it can be neoplasia in origin, which can be a primary or it can be metastatic as well. Means other metastasis, especially the splenomegaly. If there is a hemangiosarcoma of the spleen is there, that can get metastasized to the liver as well. So it will be a focal hepatomegaly as well. And primarily it can be, there is a hemangiosarcoma or carcinoma of the stomach is of the liver is there. That can also be focal in origin. Abscess and granuloma, hematoma formation, nodal regeneration, cyst and parasitic. So these are the few differential list if there is a focal. So let's start with the right side hepatomegaly. Right side hepatomegaly means what you have to look whenever you look for right side hepatomegaly means you have to look for the pylorus, you have to look for the duodenum, you have to look for the colon, transverse colon and ascending colon. Okay, so these are the structure. means this is the structure which will be enlarged, you can see, and here is the most part of the stomach will remain inside, but the pylorus can go out depending. So if you see this structure, this one the costal arch, and this one blue structure which I'm talking, this, so you have to look for this colon as well, transverse colon. So in a lateral view it will look like that. Now you see, so now you see this one. So here is the stomach, you can see the stomach, and even you can see these arrows. These arrows are basically, you can see these are basically the transverse colon, you can see the transverse colon. So you can see the transverse colon is pushed caudally as well. So this is a right side hepatomegaly. So in VD view, if you look into this one, so here is the stomach. So you can see the gas pocket where F is written. So this is the stomach. So anyway, so pectoral diagram is there on the right side. And if you look into this one, this is the transverse colon. So this is, you can see the transverse colon is pushed. So this, if you see my first, if you recall my previous first slide, you can see the transverse colon is almost 90° to the descending colon. Now you can see it's a pushed downward, and the transverse colon, it means right side enlargement is there, right side liver enlargement is there. As per my experience, VD view is much more diagnostic to diagnose the focal hepatomegaly than the lateral view. Although like, we should have a both lateral as well as the VD view as well. But you can see that a transverse colon can be easily looked. So here you see another dog. Most of the stomach remain inside the rib cage, but you can see the right side liver is enlarged. So even I can see this one. This is the transverse colon which is pushed backward by the right side, and even you can see in the red circle, most of the small intestines, they are squished backward and pushed backward near the urinary bladder. So this is a diagnostic point that the right side enlargement, the right side focal enlargement is there. So here too, if you see the gastric axis, again I'm highlighting, see the gastric axis. So observe the gastric axis. So this gastric axis is no longer parallel to the rib, but it's a caudo-ventrally, obliquely placed. So this indicates that means pylorus, only pylorus is pushed, bodies remain inside. It means pylorus side, as I told you, it is in contact with the right part of the liver. So it means liver right side hepatomegaly is there. So here too, if you see, here is the pylorus. So observe that. So these are the different animals with the focal, it's not the same animal. So I'm showing you the x-rays with the right side liver enlargement, but in different animals. You can see these one hepatomegaly is there, pylorus is, so here you see, and this is the rib cage. The limit of the rib cage, you can see even most of the stomach or most of the pylorus, whole of the pylorus is pushed out of the rib cage. So now comes to the left side. When the left side is enlarged, then duodenum and ascending colon will remain its normal position, but a descending colon will be pushed, because the descending colon is more towards the left side. So that's why you can see here is the left side enlargement. So the left side enlargement is there. Here is stomach. So because it depends upon how big, but if it's only the left lobe, left lateral or left medial lobe of the liver is enlarged, then the stomach will remain within the rib cage. This is the differentiation, and even pylorus will also remain within the rib cage. But if there is a right side hepatomegaly is there, then the pylorus will be pushed out of the rib cage. So here you see here is the VD view. Here is the, so you can see the ascending duodenum. On your left side is the ascending duodenum, then transverse duodenum, and the descending duodenum is pushed caudally. Descending duodenum, descending colon, not duodenum, descending colon. So ascending colon and transverse colon is slightly obliquely placed, and now the descending colon is pushed caudally. So this indicates that left side focal hepatomegaly is there, and pylorus and the stomach that remains. If you perform contrast radiography, barium along with it, then clearly you will see that pylorus is within the rib cage. Pylorus remain within the rib cage if there is left side hepatomegaly, but is pushed outside when it is right side hepatomegaly. So now this is also, you can see, this is the right side hepatomegaly. You can see the liver, the stomach, whole of the stomach is at this point, and even you can see the transverse colon as well as the descending colon is pushed backward, down caudally as well. So this is the left side. Means if you look into the x-rays properly, placement of the adjacent organ, you can diagnose whether it's a left side or right side or generalized hepatomegaly is there. So here too, if you see the gastric axis, so this is the left side heart, the left side liver enlargement is there. Now comes to, that was the hepatomegaly. Now comes to, even there is sometimes there is a calcification can also be seen. This is a dog which came to us almost 2 years back. So which was having calcification, liver parenchyma was having, you can see within the yellow circles, lot of calcification was there, increased opacity. So focal or diffuse parenchymal mineralization was there. So this is usually benign finding, and potentially it can be associated with the neoplasia. When this is called dystrophic calcification. So when this is dystrophic calcification, means calcification where it is present should not be there, calcification. So that is the dystrophic calcification, and this is normally indicated it's a neoplasia is there. So even sometimes there is a cholelithiasis, but that cholelithiasis calcification will be at one point only, within the gallbladder only. But this is a diffuse calcification is there. When it's a diffuse calcification, then it is mostly neoplasia. But when it is a focal one, then it can be cholelithiasis, means stone in within the urinary bladder. So even parasitic cyst can also be granulomatous disease or neoplasia. These are the different differentials are there. Further ultrasonography can help you further diagnosis. So these are the, but if you see the margins of the liver near the last rib, they are within normal limits. It means mostly in neoplasia the liver enlargement can be there simultaneously. So this case was it was a granulomatous in origin. So some granulomatous in a region, small granules was there on the liver parenchyma on ultrasonography, which was diagnosed to be. So now this was a typical case of biliary colitis, means stone within the urinary bladder, within the gallbladder, So within the gallbladder, so when there is a stone formation is there, then these type of X-ray will be visible in the lateral view. So this was a case of hepatic cyst. So hepatic cyst, you can see a big cyst was, so this was further diagnosed by using ultrasonography. So that's why in the beginning I told you, just looking into the X-rays may not be, further we might have, means both the diagnostic aid, radiography as well as ultrasonography, they go hand in hand to each other. They go simultaneously. So that was increased in the size. Even the size of the liver can also decrease. So this is called microhepatia. Microhepatia means the stomach will be shifted. Means I told you stomach is in contact with the caudal margin of the liver. So when liver will be smaller, so whole of the stomach will go more cranially near the diaphragm, especially the pylorus that will be closer to the diaphragm. So most common cause of microhepatia is portosystemic shunt, or there can be cirrhosis as well, or fibrosis is there. That is in old dogs, but in young dogs which are having congenital portosystemic shunts, or there can be in old dogs acquired portosystemic shunts can also be there. But in all these portosystemic shunts, microhepatia can be the sign in X-rays. If you look into this one, this is a small liver, and here is the stomach, and you can see it is almost near. So rib cage is quite far away. And when we did the barium swallow, you can see the swallow as well. You can see, so here is the right kidney and here is the left kidney. You can see what the gap between the right kidney and left kidney has increased. Gap between the right kidney and left kidney. Otherwise, in a normal animal, both the kidneys they overlap to each other. Means slightly the right kidney is cranially placed, and 50% overlapping is there. But here you can see right and left kidney because of the smaller liver size. Right kidney has also gone cranially. So here you see another portosystemic shunt. So you can see the stomach. So very small liver, spleen is there. So all these structures are within the rib cage. So this is about the liver. So two conditions which I discussed. Well, number of conditions I discussed, but two main conditions which are mostly diagnosed is hepatomegaly or microhepatia as well. So if there is a puppy is there which is less than 6 months of age and is having nervous signs, or there is a salivation, lot of salivation is there, and the growth animal is not able to grow like other litter mates, and there is after eating or after giving food sometimes they start showing a nervous signs. Then when you go for a postprandial, means after food you go for a markedly increased bile acids, then you should go for an X-ray to look into the condition of the liver is there, because all these conditions, all these signs and tests they indicate that this can be a case of portosystemic shunt, and there can be microhepatia as well in this case. So no doubt ultrasonography can also help you, but radiography can add up in your diagnosis as well. Let's come to the second structure, which is a spleen. So I told you the spleen, which is a structure which is attached with the greater curvature of the stomach, and the tail of the spleen is near the ventral wall of the abdomen. So the whole means body and body is almost in contact. The whole of the body is in contact with the greater curvature of the stomach. So whenever you look for these, if you know about the normal anatomy, so whenever you look for abnormal, then you should look about these organs as well. For the tail means the splenomegaly can be because of the tail in origin or can be of the body in origin, or there can be a generalized splenomegaly as well. So head of the spleen that is attached to the stomach with the gastrosplenic ligament anatomically present in the left cranial quadrant of the stomach. So this head of the spleen is because the stomach is present on the left side, so it is attached with the stomach. So that's why the spleen is also present in the left cranial part of the stomach. So the present caudal and lateral to the greater curvature of the stomach, which I already told you, it is attached with the greater curvature of the stomach. So it is cranial and lateral to the left kidney. This is another anatomical which I already discussed in the previous first few slides. So it is cranial as well as lateral to the left kidney. Body and tail, this is normally tail is mostly in contact with or present near in the ventral abdominal wall or near the let me show you the x-rays as well, then you will understand all these conditions, all these anatomical landmarks. So it can be if there is a change in position, if the spleen is changed in position, this can be because of the enlargement of the adjacent organ, like if there is a stomach neoplasia is there, or there is even I should say there is GDV, gastric dilatation and volvulus, then even then there is a splenomegaly as well as there is displacement or there is some lymphadenopathy is there, cranial mesenteric lymphadenopathy, that can also change the position of the spleen as well. So spleen can be mispositioned with displacement of the stomach in GDV due to gastrosplenic ligament. So because it is attached to the stomach, when the stomach will rotate, the spleen will also be displaced. So splenic torsion will be there. I'll be showing you the splenic torsion x-rays as well. So classic x-ray which we got in our patient as well. So in lateral view, so normally it is attached with the, it depends upon the position. If you take an X-ray immediately after giving the food, then the spleen will be pushed backward because it is attached with the stomach, so it will be pushed backward. And even in the liver, if there is a left side enlargement of the liver is there, even then it will be pushed caudally. And even it has been seen that whenever you give anesthesia or sedation before x-rays, even then the spleen can be enlarged. So left lateral view, I told you in the beginning that left lateral view is the ideal. Okay, left lateral view, right lateral view is ideal for looking for the spleen. Sometimes you may not able to see the spleen in left lateral view. So that's why go for right lateral view if you want to look for the spleen. So, so it is. Let me show you these. Here it is. So spleen is be present. That this is particularly the triangle structure which I highlighted. This is the tail of the spleen. So tail of the spleen, you can see it is just caudal to the caudal to the liver margin, and this is the tail of the spleen, and it is in generalized splenomegaly. If there is a generalized splenomegaly, then this tail will be also be enlarged, and it will push the abdomen, this small intestines, and dorsally, and these small intestine may not be visible near the ventral abdominal wall. So here you see these are the two X-ray which I am showing you. Upper one is the left lateral view, and the lower one is the right lateral view. See the difference? This structure is not visible in the upper view. So this is only visible in the lower view, which is right lateral view. So that's why it is highly recommended for if you want to look for the go for right lateral view for spleen especially. In cats, there is a difference is there. In cats, a difference is there between the dogs and cats. Even in cats, sometimes you are not able to see the spleen, or I don't know, sometimes, most of the time, you are not able to see the spleen either in the right or lateral view. So this is a species difference is there, because in cats, spleen is very small in structure, and sometimes it's not visible in either of the, but it will be visible in the VD view, ventrodorsal view. So let's see in the ventrodorsal view, if you see this structure, this one, this is the spleen. So this is the left side, and here you see the fundus of the stomach. You can see, so cranially, the cranial border of the spleen is near the fundus of the stomach, and the caudal border of the stomach spleen is near the left kidney. So this is how you should recognize in a normal animal. You can see in VD view, head of the spleen is visible as a triangular structure lateral to the stomach fundus and craniolateral to the left kidney. Craniolateral to the left kidney. So this is where you should look for in a VD view. And VD view is more diagnostic if for a normal spleen. But if it is a splenomegaly, then lateral view, I have seen the lateral view is more diagnostic than the VD view. But both views should be done simultaneously. Again, I am repeating. So in cat spleen, sometime again I am repeating, sometime normally routinely it can't be seen in lateral view, but VD view is ideal for cat if you want to look for spleen. Splenic masses can be there, means may occur, means I told you there is three parts are there for the spleen: head, body, and tail. Spleen mass can be anywhere in the three part. It can be in the head, it can be in the body, it can be in the tail as well. So it is mostly, so these are the normal, they can be enlarged. So whenever there is enlarged is there, it is going to displace the other organs as well. So these are the organs which can be affected whenever there is a splenomegaly is there. So let me show you the x-rays as well. I will show you the x-rays, especially if the head is enlarged. As I told you, the head of the spleen is placed just cranial to the left kidney, so left kidney will also be displaced. So causes, these are the few causes are there. So I told you that whenever the smooth margins are there, so whenever you look for any organomegaly, hepatomegaly, splenomegaly, or then even a kidney enlargement, then you, in addition to the enlargement, you also see about the margins, whether the margins are smooth or it's irregular margins are there. If it is smooth, it means it can be inflammatory in a region, or like especially in the splenomegaly, it's inflammatory in a region, or it can be because of some sedative, you have given sedative or anesthesia, that can also lead to splenomegaly. But that spleen will have a smooth margins. But if there is any disease which is like lymphosarcoma or hemangiosarcoma or mast cell tumor is there, then can lead to diffuse infiltrative irregular margins of the spleen will be there. It means from the margins you can have an idea whether there is an inflammatory process is going on or some neoplastic process is going on in the spleen. So even vascular stasis, splenic torsion, inflammatory, these are the different causes of splenomegaly. splenomegaly as well. So even ehrlichiosis, this is another thing which I want to discuss right now, because this is also known as tick fever. So tick fever is very common in our country, especially when there is a summer or rainy season is there. So ehrlichiosis can also lead to generalized splenomegaly, but that spleen will have a smooth margins. So if you look into this one, if you look, this is generalized splenomegaly. If you look, let me highlight this one. Let me again highlight this one. And here you see this one. So this is a VD view and a lateral view, head, body, and spleen, head, body, and tail. So you can see the tail of the spleen is almost near the urinary bladder. In VD view, I'm talking about. So even in a lateral view, you can see the tail of the spleen is almost near the urinary bladder, and you can't see any small intestine near the ventral abdominal wall. This point will differentiate that this is splenomegaly, not hepatomegaly. Okay, in hepatomegaly, small intestines will be visible touching ventral abdominal wall. But in generalized splenomegaly, the small intestine will be pushed dorsally and will not be visible touching the ventral abdominal wall. So intestine pushed dorsally with a soft tissue density underneath. So minimum or no evidence of intestine loop near the abdominal wall. So this is generalized abdominal wall. So here you see the left kidney. Left kidney, you can see left kidney will be pushed quite quite caudally, because left kidney is in contact with the head of the spleen. When head of the spleen has a lesion, then it can push the left kidney as well, because I told you the left kidney is mobile in nature, not like a right kidney. Right kidney is fixed in position because it is attached with the liver. So that's why when the spleen is aligned and you see the left kidney is also displaced caudally, then the lesion can be either generalized hepatomegaly, or there is focal focal splenomegaly involving the head of the spleen. Here you see the stomach. Here you see the stomach. So you can see, even because initially I told you when I showed the slide of anatomy as well, I told you that spleen is in contact with the stomach. As the spleen has a light, it will push the stomach cranially. So you can see whole of the stomach is near 9th to 10th intercostal space. Normally, it is normally present at the level of 10th to 13th intercostal, 12th intercostal space, but now it has pushed cranially because of the enlarged spleen. It has pushed cranially as well. You can see the stomach is pushed cranially here. So this is how you can demarcate and you can come to diagnosis that which part of the spleen is enlarged. Here you see the spleen. This is generalized splenomegaly. Again, I'm repeatedly highlighting so that you should able to see, and even you can see the stomach. Stomach is pushed cranially and the small intestine is pushed dorsally. So these are the different patients which I'm showing you. So this is also splenomegaly. So you can see the splenomegaly, and even you can see this is hepatomegaly. Now to differentiate, if you see the small position of small intestine on your left side X-ray, or most of the small intestine is present dorsally, but on your right side X-ray you see the small intestine is near the ventral abdominal wall. So this is how you differentiate between splenomegaly, although the structures are both the structures are quite near to each other, and sometimes enlargement can lead to misdiagnosis. So position of small intestine can help to differentially diagnose between these two organomegalies. Now you see even here is the liver and here both the liver as well as spleen is aligned as well. Both the liver, so both are, but they are smooth margins. So previous slide, if you see, these are not smooth margins. These are quite irregular margins are there. So this is mostly neoplastic in origin. But here, if you see, this is splenomegaly. This is mostly inflammatory in origin. This splenomegaly is mostly inflammatory because smooth margins. So here you see. This is also splenomegaly and have a smooth margins. This is inflammatory in origin. So splenomegaly on lateral view of the cat. So even lateral view is visible. If a normal cat, this spleen is normally not visible. But if it's visible in lateral view in a cat, it means there is a splenomegaly is there. So here so this is a classic X-ray which came to us in an emergency probably 5 months back, 5 to 6 months back, and this was a case of splenic torsion. You can see typical C shape. This is called reverse C shape appearance of the spleen, and this when you see such type of reverse C shape appearance of the spleen, then it indicates that there is a splenic torsion is there. So splenic torsion can be with GDV, gastric dilatation with volvulus, or it can be without GDV as well. So both way it can be. And this splenic torsion is without GDV. So here you see reverse one. So this is so another X-ray I'll show you this one. This is also reverse C, reverse C appearance of the spleen. This is typical sign, radiographic sign of splenic torsion. So if there is a focal means only a part, means head or the tail of the spleen is aligned. So this is normally, these are the all structure things which I already told you like in the beginning. So there are few etiological points are there. Causative age can be neoplasia that involves only a part of the spleen, either the head or the tail or the body. So accordingly, the focal enlargement, accordingly, the organs will be displaced. So let's see this one. This is a focal one. Here you see only the tail is enlarged. So only tail is enlarged. So here the intestines will be pushed and will not be visible. So this is a common character you have to look for in almost all splenomegaly cases. But stomach is remain. You see the stomach. If you see the stomach is in its normal position, it means it's a focal splenomegaly, but not generalized splenomegaly. Means had it been a generalized splenomegaly or head is involved, head of the spleen involved, then the stomach would have pushed cranially. So here you see the whole of the tail. You can see the tail of the spleen is having a hemangiosarcoma. This case was having a hemangiosarcoma. You can see the small intestines are pushed dorsally as well as caudally as well. So you can see another splenomegaly. So you see here you see the liver as well. So here you see the stomach. So tail of the, because it's a tail is involved, tail of the spleen is involved. So that's why stomach is almost in a normal position, and the small intestines are upward. So here you see the tail, and even this stomach is its normal position. So only the tail, focal splenomegaly is there. Focal splenomegaly is there. Here too you see the focal splenomegaly, and here too you see this focal splenomegaly. Only the tail has its irregular margins. When it's irregular margins, then it means it can be neoplastic in origin, or it can be abscess as well. But you have to further go for diagnosis. It's not a simple ehrlichiosis or it's not inflammatory in origin as well. Here you see these focal splenomegaly. Now comes to the third structure, which is pancreas. So this is also important, although like in a normal animal, pancreas is not visible. Pancreas is not visible. It's very soft tissue structure which is present on the medial side of duodenum. So that's why, so we have to look for the angle which I showed you about in the beginning, gastroduodenal angle. You have to look whether it's acute or it's an obtuse or more angle has increased. So you can see here you see the pancreas will be placed. This is the lateral view, lateral side of sagittal, when you sagittal view of the dog. When you look from the lateral side, pancreas is present at this point. Means just on the medial side of the duodenum and near the stomach. So you see the pancreas in close proximity to the duodenum and the greater curvature of the stomach. So not visible on X-rays, but if you go for contrast, and if you can highlight, you can see this descending duodenum. If you see the descending duodenum, so it is because as I told you, the pancreas is present on the medial aspect of the descending duodenum. It means the position of the pancreas. In this position, you have to look for pancreas. This position you have to look means it just caudal to the stomach, greater curvature of the stomach. You can see here again I'm again with this one. So duodenum. So here in this position lies pancreas. Oval circle, white oval circle. This is the position of pancreas. So whenever there is pancreatitis inflammation of pancreas, then the duodenum will be pushed laterally. When it will be pushed laterally, then gastroduodenal angle will be disturbed. So gastroduodenal angle will no longer remain acute in position. Let's start with the pancreatitis. So initially it may not be visible in X-rays, but if there is advanced acute pancreatitis with a lot of swelling in the pancreas, then it can be visible as a ground glass appearance caudal to the stomach. So I'll show you those one in VD. So you have to look for gastroduodenal angle as well. So I'll show you those ones as well. If you look, this was a typical case of peracute pancreatitis and pancreas was swollen. So if you look into this one, this structure, again I'm highlighting so this is the stomach. This is the stomach, and if you look into the for the duodenum, if you see, this is the duodenum. Here is the duodenum. So this is no longer an acute angle. Now it's an obtuse angle, more than 90-degree angle is there. And here you see there is a ground glass, more whiter, means there is some inflamed structure is there at this place, and structure is pancreas. So that's why there is a localized, sometimes there is a, because whenever there is a pancreatitis is there, focal peritonitis normally happens. So that peritonitis is also visible in this dog. So let me show you in lateral view. If you look into the lateral view, observe the whiteness, increased whiteness, ground glass appearance, caudal to the stomach, and even you can't see the kidneys as well because it's all inflamed at this point. When it's inflamed, there is increased radiopacity, focal peritonitis, so that can lead to ileus as well. Here is the stomach. Here is the stomach. You can see in a normal animal you will not see like such a increased radiopacity just caudal to the stomach. So here you see the focal or local or focal, you can say peritonitis as well. Here you see. So means why I called it as a focal or local peritonitis, because the serosal detail of the intestines are not clear. You can't see the outer wall of the intestine. To some extent, it is visible near the urinary bladder. But in this point, in this circle, because the pancreas normally inflammation, that also lead to localized peritonitis as well. So that's why these 2 points when are present, then you should go for further testing for CPL as well. Canine pancreatic lipase is there, amylase or lipase enzymes estimation as well. So these things has to be. So solely on the basis of radiograph, sometime may not be possible, but you have to go for further other diagnosis, ultrasonography, you have to go for blood testing as well. But X-ray can give you fairly good idea that there is some alteration at this point, and it can be these the differentials. Then pancreatic neoplasia can be there, as you know that there is normally pancreas is present medial to the duodenum and caudal to the stomach. So that's why there is these structures will be can be easily displaced. You can see here if you see there is this is a pancreatic neoplasia. You can say pancreatic neoplasia is there. So stomach will be displaced cranially, and there is a lot of peritonitis as well. So here you see this one. This was a pancreatic neoplasia. So from the position, although like it looks like it's not, although look like a tail splenomegaly involving the tail, but it's not a tail because the tail normally touches the ventral side of the stomach. But it is already, because I told you that duodenum is fixed structure. Unlike other part of the intestine, duodenum is almost fixed because it is attached with the liver, with the ligament, it is attached with the colon. So that's why and pancreas is attached with the duodenum. So whenever there is enlargement or some neoplasia is there, it will not touch the ventral aspect of the abdomen. It will be in the mid-abdomen region. So this is a case of pancreatic neoplasia. Here you see the pancreatic neoplasia in VD view. Now comes to my last part, that is, this was about the cranial normal radiographic anatomy I already discussed. Then I discussed about the radiographic anatomy, normal as well as abnormal cranial abdomen. Now the third part is that radiology of urogenital organs I'll be discussing. In this, I'll be discussing about the normal, how to look for the kidneys, whether the kidneys are large or within normal limit, how to look for these ones. And then I'll be discussing about the contrast contrast intravenous pyelography. If you want to, if there is a no doubt. No doubt, there is ultrasonography has replaced with radiography from radiography in case of urinary system. But there are few conditions are there which I'll be discussing, which can be exclusively diagnosed by using contrast intravenous pyelography only. So later on, I'll be discussing those things as well. So there is no alternative to radiography. So kidneys and ureters are there, urinary bladder, urethra, prostate, and uterus. So these all will be discussed in next slides. So what you have to evaluate for kidneys, you have to evaluate the size, you have to evaluate the shape. So I always stress that if you look for the size, if the size is increased or decreased, then you should look for the shape as well. Then you have to look for the margins as well. Margins are smooth or irregular. Size increased, how much it has increased. So these are the things are very important to diagnose a particular disease. Even position and opacity, that's also very important, whether the kidneys are its normal position, and if it is kidney enlargement is there, what other organs, which other organs have displaced, so that we have to see as well. How much they have displaced, that can tell you about the extent of enlargement. So as you know that the kidneys are present in the retroperitoneal space. It is not in the peritoneum, but it is in the retroperitoneal space. So it is present in the retroperitoneal space. So that's why whenever there is enlargement is there, so it will push the small intestine ventrally, because whole of the retroperitoneum will be pushed downward. So that's why it is present in the retroperitoneum, and in canine kidneys are normally bean shaped. So if you see that I have marked T13, L2, L4. My idea is that T13 and L4, these are the limit for both the kidneys. So if you look into the right kidney, as I told you, right kidney is in fixed position and is cranially placed. Left kidney is mostly free in position, free in nature, and is caudally placed. And the cranial pole of the right kidney, that is normally at the level of T13, and the caudal pole of the left kidney, which is caudally placed, will be at the level of L4. It means these are the limits for the normal. In a normal animal, normally they are placed between T13 and L4. So if you look into this one, this is the right kidney and this is the left kidney. And if you see, the cranial pole of the right kidney is at the level of T13 and caudal pole is at the level of L4. And in dogs, normally the kidney is 2.5 to 3.5 times length of L2. This should be the within limit size of the kidneys. If it is more than 3.5, more than 4, like around 4 or 5 or more than that, it means there is a kidney enlargement is there. So this can be a landmark when you look for kidney enlargement in an X-ray. So kidney is normally in the retroperitoneal space. It is placed between T13 and L4. So these are the limits for both the kidneys. Kidney position is altered due to excess of retroperitoneal fat, or there is a gastric dilatation is there, then left kidney can be altered, or there is extra renal mass. Extra renal mass means if there is adrenal glands are involved, there is adenoma or adenocarcinoma of the adrenal gland is there, then it can be displaced away from its position. But normally, being in a retroperitoneal space, they remain in its normal position as well. So here is the right kidney. So there is a left kidney. You can see the position in a lateral view, the position of these kidneys, left and right kidneys as well. You can see they overlap to 50% of the right kidney and left kidney, they overlap to each other. But cranially, right kidney is placed, caudally, left kidney is placed, and normally they are placed like they are bean-like structure. But in contrast, if you look into the X-ray, into the cat kidneys, they are not bean shaped, they are round in shape. You can see they are round in shape, but in dogs it is bean shape. Here you see both the kidneys are more rounder than. So this is a differentiation point. Means if you look into the kidney of a cat and it looks like a rounder, don't take it as any pathology. This is a normal in nature. So rounder kidneys are normal in cats. So let's come to a very important part which I want to discuss right now is contrast radiography of the urinary system. It is called excretory urography or intravenous pyelography. Although like this ultrasonography has replaced this procedure, but there are few procedures are there where few anomalies are there, few disease processes, just like ectopic ureter, or there is a rupture of kidneys, or there is some rupture of ureter, or there is a ureteral dilatation is there, then ultrasonography may not be helpful. Then IVP is the technique of choice, then that can help you in diagnosis as well. So indications are there. So if there is a indirect assessment of renal function, yes, this is a very important, which will differentiate if you want to assess that whether the renal function is maintained or not, proper blood supply of the kidneys there is not, or proper there is a filtration, kidney is able to filtrate, then IVP can be better choice than ultrasonography. Then if there is any kidney enlargement is there, kidney disease, so change in the shape, size, margin, integrity, or there is a mineralization is there, and you want to see the cause as well. Although ultrasonographically it can be found, but if it's ultrasound facility is not available, then this can be the technique which can help you in the diagnosis as well. If you suspect then ureter disease, one thing I must tell you that ureter disease are better diagnosed by IVP than ultrasonography. So even especially the ectopic ureter, if the ureters are abnormally placed, ectopic means ureter abnormally placed, not entering into the urinary bladder at a normal place, but it is opening up abnormal place. Abnormal place means just inside the, especially in the female dogs, just inside the genitalia. Then it means this is a typical case of ectopic ureter, which may not be diagnosed with the help of ultrasonography, but can be diagnosed with IVP. So then suspected for trauma, if there is a hit by a car or trauma to the patient, and you suspect that there is a ureter rupture is there or kidney rupture is there, and if you want to diagnose or that there is some rupture is there or not, then IVP can be the better choice than ultrasonography. Urinary incontinence, especially in the female dogs, urinary incontinence is there because of the abnormal placement. I will show you those x-rays as well. So abnormal placement of ureters that can lead to urinary incontinence, especially when animal is sleeping. When animal is sleeping, laying down or resting, and urine continue to drain out, it means this is a case of urinary incontinence, maybe because of the ectopic ureter. So here you see assessment of potential involvement of kidneys and ureter in abdominal masses. If you want to see, means if there is a abdominal masses are there, so splenomegaly, organomegaly, any organomegaly is there, and you want to see that whether this organomegaly, multiple organs are involved, means other kidneys are involved as well or not. Then if you want to differentiate, then IVP can be the technique which can help you to differentiate whether kidneys are involved in that abnormal masses or not. So this is another indication as well. But let me differentiate. This procedure has been largely replaced by transabdominal ultrasonography, but let me differentiate as well. IVP and ultrasonography means if you want to go for renal abnormality, parenchymal renal abnormality, then better go for ultrasonography. But if you want to go for any mass as well, then ultrasonography can be. But if you want to go for nephrectomy, and before nephrectomy, you want to be sure that whether this kidney is functioning properly or not, then both can be done, but I will prefer go for IVP. Then if ureter evaluation, this is the point where the ultrasonography may not help. If ureter evaluation need to be done, then IVP is the method of choice. And if you want to evaluate the urinary bladder, when catheterization need to be done, then ultrasonography is the then if you suspect that there is a renal trauma is there, which I already told you, and there is a fluid accumulation in the retroperitoneal space, as I told you that the kidneys are present in the retroperitoneal peritoneal space. So if there is a fluid accumulation is there and you suspect it can be because of ureter trauma, ureter rupture, or because of the kidney rupture, then IVP can be the best choice for it. So, but there are few contraindications are there. Means if there is a patient is dehydrated and uncontrolled, there is congestive heart failure and animal is sensitive to some contrast medium and severe renal failure is there, then we should not go for IVP. But azotemia is not contraindicated. If the azotemia is there, but animal is properly hydrated, then IVP can be done. So technique is, so these are ditrizoate. So ditrizoate can be is a contrast medium. This is a ionic iodonated contrast medium which can be used, which can be given intravenous as well. So although it's a little costly, but it's worth it. You can use it. So we can use for IVP and we can use for contrast, positive contrast cystography as well. If you want to highlight the urinary bladder. Just for example, recently what we did is that there was a case, accident case, and we were suspecting that on ultrasonography it was found that there is some fluid is there in the stomach, in the abdomen, sorry, fluid in the abdomen, and we were not able to differentiate. Then we thought that it can be a urinary bladder rupture. Then we injected this ditrizoate into the urinary bladder, and we saw that whole of the contrast medium that had entered into the peritoneal cavity. So then we came to diagnosis, yes, this is a case of urinary bladder rupture. It means this contrast dye can be used for IVP and as well as for cystography as well. It means to highlight the urinary bladder. So it comes as a 800 milligram per kg is to be given. So it comes as a 370, concentration is 370 milligram per ml. So 2 ml, roughly 2 ml per kg volume is to be given. It can be given as a bolus as well. So survey radiography has to be done and lateral. So whenever you give, so there are few phases. Technique is there for IVP. When you give the bolus, within 30 seconds, you have to take an X-ray. Then after 1 minute, 5 minutes, 15 minutes, 30 to 40 minutes, you have to take these serial X-rays. What is the idea? Idea is you have to see that whether the proper opacification means highlight. Kidneys are highlighted properly, and slowly that opacification decreases with the time. That will show you, that will tell you that the kidneys are functioning properly. If the opacification is proper and then fading of the opacification is with the time, then this will help you to tell you about the kidney functions. Then another 5-minute oblique view is done. Means these views, serial radiography has to be done immediately after injection. You can see there are 3 phases are there. Arterial phase, which has to be taken immediately. So you can see here the kidneys are opacified clearly after IVP. You can see the kidneys are clearly visible. In normal survey, it is not so clearly visible, but this main blood vessel is also visible. This is called arteriogram because this contrast is going through this major blood vessel into the kidney parenchyma. This is called arteriogram. So this is so opacification of blood vessels. So this will happen within 30 seconds of giving the bolus of ditrizoate. So after so now after 1 minute, slowly, so the nephrogram will be there. So kidney will be highlighted. If there is kidney enlargement is there and you want to look for the kidney enlargement, then IVP can be done if ultrasonography is not available. So you can see immediately, so kidneys are opacified. After 20 minutes on your right side, slowly, you can see the ureter is highlighted, and the opacification of the kidneys has decreased to great extent. So here you see the kidneys, here you see the other. So see the opacification, the whiteness of the kidney is decreased with time. So these are the things you have to see in IVP. So here now comes the pyelogram. That was first was arteriogram phase, which comes immediately. Then after 1 minute comes the nephrogram when the kidney parenchyma is highlighted. Then comes the pyelogram when the pelvis, renal pelvis is highlighted. So this is renal pelvis. Normally it should be like this. So within 2 to 5 minutes, it will start highlighting, and within maximum 20 minutes, whole of the pilus, renal pelvis will be highlighted. You can see these are the measurement. You can even measure that how much is the pelvis diameter, renal recess diameter, and these are normal limits. And even it looks like a horn of the male deer. We call it as a stag horn. This stag horn appearance, it shows that kidneys are functioning fine. But if there is any enlargement is there, any changes are there, so let me tell you about these enlargement. So if you see this kidney is enlarged, when this one right kidney is enlarged as compared to the left kidney. So when here too you can see another case which kidney is enlarged. So here too there is a pyelonephritis in a cat in which kidney is enlarged. So here too right kidney. So these type of cases can is ideal for ultrasonography to look for that cortex medulla size of the pelvis, or if ultrasonography is not available, then you can go for IVP as well. So here you see the kidneys, but these kidneys are irregular in shape. This is a chronic pyelonephritis having irregular shape kidneys. So you can see even these are these are big kidneys. So these are the big kidneys. You can see when there is a big round shape kidneys, but these kidneys have pushed the small intestine towards the other side, and even you can see it is pushed downward in lateral view, in VD view towards the opposite side. So these are so here you see the descending colon is also pushed ventrally. So this is a typical case of hydronephrosis. So what is hydronephrosis is when there is because of any ureter obstruction, there is a back pressure is there, or there is excessive back pressure. So that leads to enlargement of renal pelvis. So this is hydronephrosis. And so this is on your left side is a normal kidney after IVP and hydronephrosis on your right side. So you can observe that the renal pelvis has enlarged to a greater extent. So this is typical case of hydronephrosis. So although like nowadays these technique is not so commonly used for these hydronephrosis, because ultrasonography is very commonly available at our hospitals. So now comes to this is also this is a normal one. This is hydronephrosis. So and now comes to the condition in which called renal neoplasia. Renal neoplasia means when there is any tumorous involvement is there, or it can be a carcinoma as well as, or lymphosarcoma can be there. Most common primary tumor in dog is renal carcinoma, whereas in lymphosarcoma is the most common cause for in cats. So radiographically, so whenever there is a renal enlargement is there, so it will be irregular in shape if there is a renal renal neoplasia. So that's why I want to tell you right now is whenever there is a hydronephrosis there, then the margins will not be margins will be regular. But if there is a renal enlargement because of neoplasia, then mostly the margins of the kidney will be irregular in shape. So descending colon will be pushed ventrally. Small intestines, they will be concentrated on the ventral side of the abdominal wall. Here you see the kidneys. They are irregular. These you can see the irregular in shape. You can see irregular in shape in cat, which is having a lymphosarcoma, and you compare it with the red box, which is L2. So you can see it is more than almost 6 times the length of L2. That indicates, that shows that there is a renal neoplasia because of the lymphosarcoma. Lymphosarcoma is the most common cause of renal tumor, renal neoplasia, you can say, kidney neoplasia in case of cats. So here is a renal renal carcinoma in case of dogs. You can see, observe in triangle, you can see these small intestines are pushed downward, and as well as laterally it looks like a lateral opposite side small intestines has accumulated or pushed. So you can see even here too the small intestines are pushed because of the big kidney neoplastic neoplasia. You can see even here, you see the kidneys, big kidney, it has pushed the intestine to opposite side. No, small intestines are not visible towards the right side of the abdomen. It is mostly on the concentrated or pushed towards the left side of the abdomen. It is because of the kidney neoplasia of the right, involving the right. Means from the position of the small intestine, you can easily see whether it's a right side kidney is involved or left side kidney is involved. If the kidneys are, if the small intestines are pushed towards the left side, it means it can be the right side kidney is involved. So here the ureters. So when you look into the ureters, so if you look into the, normally it can't be seen in a survey radiograph. So evaluation has to be done with the IVP. If you look into this one, ureters, so these are during the course of means this is a normal, in a normal animal, how the ureter should be entering into the urinary bladder. You see the ureters are entering into the trigone. It is a forming a hook. If you see, look into this circle, you see the ureter are forming a hook like structure, and then it is entering into the neck of the urinary bladder. We call it as a trigone. So it means if it is ectopic, ureter is abnormally, then the structure will not appear like this. It will be abnormally placed, more caudally. It will be more caudally placed. It will open up more caudally. Then it is called ectopic ureter, and which can be a cause of urinary incontinence. So this is normal, which I want to show you, that you should know how the ureter will enter, or they enter into the neck of the urinary bladder. So instead of opening in the trigone, if they open it wrong place in urinary tract, then IVP can help you to track the way. Here the urinary ultrasonography, abdominal ultrasonography normally fails. IVP can help you to diagnose such cases. Now come to urinary bladder. So if you see the urinary bladder, normally it is visible, quite visible on the caudal aspect. So normally it can lead to the displacement. These are different causes which can lead to a displacement as well. Opacity can be increased because of the inflammation, because of the stones. Shape can alter as well, depending upon how much urine is present, and it can alter the position as well, because we have seen that urinary bladder can herniate through perineal hernia as well, into the perineal sac, as in case of perineal hernia. Or even sometimes in the ventral hernia, it can be displaced through the hernial ring. It can go into the hernial sac. So that can lead to the displacement as well. And if it is not visible properly, you can't diagnose where the urinary bladder is, then you can easily go for cystography as well, which I'll be telling you later on. Here you see the different stones are there, but this right side X-ray was dog was also having stones, but right side was having a radiolucent stone, urate and cystine stone. But on the left side is the radio-opaque stones, calcium oxalate and struvite. Means from the X-ray you can even see, you can judge the composition as well. Even this silica stones also, they also appear as a radio-opaque. But calcium oxalate and struvite will appear like that. And if there are stones are there but not visible in the, so it means those stones are mostly urates and cystine. Even X-rays, even in contrast cystography, we can even diagnose the radiolucent stones, presence of radiolucent stones. So I'll be showing those X-rays as well. Let me go for cystography. So cystography means contrast highlighting the urinary bladder by pushing the contrast agent. So these are the few indications are there in which if there is a blood in the urine, pus in the urine, protein in the urine, crystals in the urine, difficulty in urination or recurrent, there is UTI is there. So that can also be. Positive contrast means same ditrizoate. So if you ditrizoate, if you push into the urinary bladder, so then it becomes a positive contrast. So these are the different indications are there. If you want to see the localize the urinary bladder, if you suspect the urinary bladder is ruptured, if you want to assess the wall size as well, especially cystitis, I'll show you the X-rays as well, in which we have diagnosed cystitis or thickening of the wall of urinary bladder by cystography. So technique is, so you have to fill the urinary bladder with 20% iodonated contrast, means ditrizoate. It comes as a urographene. Cystography is the trade name, and approximately 2 to 3 ml is given into the urinary bladder. So double contrast cystography can also be done, in which both air as well as contrast can be injected into the urinary bladder simultaneously. Here 4 to 11 ml of contrast medium like ditrizoate given, and in cats 0.5 to 1 ml is injected directly into the urinary bladder after catheterization, and then you have to fill with air 5 to 8 ml of per kg of the air fill. Then it becomes a double contrast. So there is indication out there. So you have to take these views as well. You then even have to repeat these views as well. So you can see margins of if you want to see the margins by, so then positive contrast cystography is the best way in which you can see the position, integrity, and shape as well. So I will show you the x-rays in which we were able to diagnose urinary bladder carcinoma by positive cystography. Here you see the negative. This is how it will look like. So it will look like, here is the contrast one. So this double contrast cystography is used if there is any diagnose the mural wall as well as intramural diseases there, especially if you suspect that there is some stone is there which is not visible in survey radiograph, and it is radiolucent stones are there, then it means then we can go for double contrast cystography. So cystography, so these are the all techniques, these are the all indications are there. So here it is, if you see the, so if you see, go for double contrast radiography, and if you see there is a filling defect in the middle and that has a hazy border, then it means these are the case of radiolucent stones. Radiolucent stones will be normally with a hazy border in double contrast cystography will be found in the middle of the urinary bladder. But if there is a on periphery, if you found these type of, then it is blood clots are there, and air bubbles sometimes they can also, but they are regular in shape. Let me show you. This is double contrast cystography was done in a dog in which there was radiolucent stones are there. You can see these type of radiolucent stones will be visible like this, almost in the middle of the urinary bladder. So in contrast radiography, in double contrast double cystography. So here is the air bubble will be looking like this, but mostly will be in the periphery. And here is the bladder neoplasia, which was diagnosed by putting the positive contrast ditrizoate directly into the urinary bladder. So this was a case in which there was a frank blood was coming in the urine. So then we have to give the positive contrast directly into the urinary bladder, and it was a filling defect. Filling defect is basically means where the positive contrast can't enter into at that place. It means there is a filling defect is there. Positive contrast is not able to reach. It means there is some growth is there which doesn't allow the contrast medium to enter at that place. So this was the case of it was a bladder neoplasia. So although like ultrasonography can be done in such case, but if it is not available, then this can be a technique of choice as well. So most common cause is transitional cell carcinoma, may occur anywhere, but bladder neck is the most common site. So here you see there is a this was a case which was diagnosed recently because cystitis. So it was a doubtful in ultrasonography. Then double contrast cystography was done. If you see the double contrast, now the normal X-ray. Now if you let me highlight, this is the wall. Here you see the wall is quite thickened. And if you compare with the normal without cystitis, this thickened wall, it was a case, this was diagnosed as a cystitis. That is because of the increased wall thickness. And double contrast cystography was the technique which help us to diagnose this cystitis. So this was a case which I discussed recently. It came with a trauma, and ultrasonography showed that there is some fluid in the abdomen, but we were not sure where the fluid is coming. Then we did we pushed the contrast, positive contrast into the urinary bladder, and that contrast leaked into the abdomen. Then we came to know that this is a case of urinary bladder rupture. So now comes the prostate gland. So prostate gland. So this is caudal to the urinary bladder. Sorry, let me on the light because it's position of the prostate gland is just caudal to the neck of the urinary bladder, and it is just ventral to the rectum. So whenever there is a prostatomegaly is there, increased in the prostate size is there, what will happen, because it is present in the caudal part of the urinary bladder near at the level of the neck, so it will push the urinary bladder cranially. And because it is just dorsal to the prostate gland is the rectum, and if there is a prostatomegaly, it will push the rectum as well. So ultimately, in an X-ray, you will see that there will be narrowing of the descending colon or rectum, as well as the urinary bladder will be pushed cranially as well. So these are the two signs. I'll show you those as well. So here you see the prostate. Here you see the prostate, and in the VD view here the prostate is visible just in the pelvic diaphragm. So this will be visible. So here you see how to measure whether it's a normal size or not. So what you have to do is you have to look for S3, most ventral aspect of the S3, and here you have to draw a line from obturator foramen and then another slanting line where they meet. Then you have to draw the line, this from S3 ventral aspect. So then you have to measure this one. This pelvic inlet, this is called sacropubic diameter. So then you have to measure this sacropubic diameter with the size of prostate. So normally rule of thumb is that this prostate diameter should not be more than 70% of the diameter of the pelvic inlet. Pelvic inlet means sacropubic diameter. So if there is a hair, this is sacropubic, here is the prostate. So it should not be more than exceed 70% of the big. Smaller arrows should not be exceed 70% of the bigger arrow. But here if you see, these are the different causes of the prostatomegaly. So these are different, everybody knows. So these are the signs which will be visible on X-rays. Cranial displacement, urinary bladder, dorsal displacement of the colon. So there will be prostate will be cranial to the pelvic brim. So more than 70% size of the prostate when you compare with the sacral pubic diameter. Here you see this one is the rectum. You can see the narrowing of the diameter of the rectum, and here you see the sacropubic diameter. Here you see the prostate. You can see almost equal size or even bigger than that one. It means this is typical case of a prostatomegaly. Means this is how you can justify or how you can diagnose or that whether it's a prostatomegaly. Means you can compare the size of sacropubic diameter with the pelvic this prostate diameter. So you can see if it is more than 70% blue, if the red line is more than 70% of the blue line, it means prostate enlargement is there. Here you see the urinary bladder. You can see whole of the urinary bladder, means whole of the urinary bladder is pushed cranially because of the enlarged prostate which is present at the level of the neck of urinary bladder. Here you see this was a case. You can see from X-rays it looks like there is a big urinary bladder, but what we did is we have to diagnose that whether it's another problem or it's then what we did is we pushed positive contrast into the urinary bladder. You can see very small urinary bladder is present on dorsal. So whatever the big organomegaly is visible, that was a case of a paraprostatic cyst. So you can see it can be diagnosed by cystography. Survey radiography can give you misdiagnosis that it can be because of even it looks like some splenomegaly as well, or some lymph node enlargement as well. But now you can see with the positive cystography, it can diagnose as a paraprostatic cyst. So observe the contrast medium that entered into the urinary bladder only. So here is a prostatic neoplasia. You can see the prostatic neoplasia here, irregular structure, but this is the structure which you have to look. You can just below the lumbar vertebra, there is a dystrophic calcification is there. So when there is a dystrophic calcification, abnormal calcification is there, and along with it, there is enlargement of prostate, then you should further evaluate prostate. It can be prostatic neoplasia. So then contrast medium can be pushed into the urinary bladder. You can see when there is a percolation or infiltration of the contrast medium into the prostate gland, then it is suggestive of prostatic neoplasia. So you can see how means handy this technique, cystography, positive cystography, negative cystography can be there, can help you to diagnose even the conditions which can't be diagnosed by survey radiography as well. So this is a typical case history in which positive cystography help us to diagnose prostatic neoplasia because of the percolation contrast medium has entered into the parenchyma, prostatic parenchyma. Here you see. So this is another case in which there is enlargement, but when we did a negative contrast histography, then urinary bladder was highlighted. All behind or caudal to the urinary bladder was prostatic carcinoma. So it was diagnosed with the help of negative. Means start doing these type of techniques, and you will come to very good diagnosis, even with the simple radiography as well. So let's discuss an interesting radiograph which was sent to me by Dr. Sarojini. I think probably she might be there in audience as well, from Mumbai yesterday, because I just taken a permission from her as because she sent me, and then we were able to diagnose by cystography. That's why I want to discuss with my fellow vets as well. So this was the case. This was an X-ray which she has sent to me. And she said that there is some organomegaly is there too, so there is some confusion. So what we did is, so in lateral view, so there was two organs which was looks like two organs are enlarged. You can see round ones, one big one. There is another one which is near the pelvic inlet. In VD view, this mass was visible as well. So now we were confused. Although ultrasonography was done by Dr. Sarojini, but still there was some doubt was there in the mind that what can be. That what we did is then small intestines. You can see the small intestines were pushed cranially as well. So this was the round big structure circle. This can be diagnosed as splenomegaly, focal splenomegaly. But I told you that in splenomegaly, the intestine will be pushed dorsally and caudally, not cranially. Now you see the yellow rectangle. If you see that those small intestines are concentrated on cranial aspect. So now what we did is, now what we did is, it was decided that negative contrast radiography using air will be undertaken. Then what we did, we evacuated the urinary bladder. Then Dr. Sarojini did the catheterization. Whole of the urine was evacuated. Then air was pushed inside the urinary bladder, and then we were able to highlight the urinary bladder. We were able to highlight the urinary bladder. You can see the big air bubble is there. So, and there is another structure which is visible caudal to the big bubble. That was a prostatic cancer. It was a prostatic neoplasia. So you can see here the spleen was started visible. You can see previously even spleen was not visible. Here the spleen was not visible. But when the urine was taken out after catheterization, spleen was visible clearly, liver was clearly visible, and urinary bladder was having air. We did negative cystography, and even the wall, we can see the wall of the urinary bladder that is also thickened. This is a typical case of cystitis, as well as there was prostatic neoplasia, which was confirmed later on by ultrasonography as well. So earlier it was a little bit confusing with it, but so at that point, positive ditriazonate was not available. Had that ditriazonate, means positive contrast medium available, then we would have pushed at that point. Then there can be infiltration or percolation of the contrast medium inside the prostate. This case will have a percolation of the contrast inside the prostatic parenchyma. Then that could have further confirmed as a prostatic neoplasia. Now this was an interesting case which I want to. Here is the prostatic neoplasia. So earlier it was not visible. It looks like a too big structure, which can be splenomegaly, or it can be because of lymphadenopathy. But you can see with the help of negative contrast, we were able to diagnose that this is a case of prostatic neoplasia and cystitis as well. So now comes to the last part, is the genital tract. Normally the genitalia of the female is not visible in a survey radiograph until unless there is a pyometra is there. So pyometra, so uterus normally is also not visible. Here you see the kidneys, right kidney, left kidney, and here the descending colon, and urinary bladder is at this point. Then one kidney, left kidney at this point normally is present. Normally it's not visible, it should be, but if here the oviduct, this is the normal structure which will be which you can expect in a survey radiograph. But if there is any ovary tumor is there, or if there is ovary cyst is there, big ovary cyst is there, then you have to look at these points. My idea of telling you about the normal anatomy is that these structure can be visible at this point. Here too, if you see the kidneys, these two, right and left kidney, and this one urinary bladder, here the ovaries will be visible, not visible, you can expect in a normal animal. Here, so location of ovaries is like here is the kidney, and here is on the lateral side is the location of the ovaries. They are normally present, not seen in. But if there is a cyst, granuloma, teratoma, neoplasia, bursal abscess is there, and if you see some abnormal structure just lateral to the kidneys near the abdominal wall, then the first thing should come in mind that ovary might be involved. So here you see in a fatty animal, sometimes some normal ovary can be visible here, sometime maybe, but not in normal. But if there is a lot of fat is there in the abdomen, then it can be little bit, because fats, they can highlight the abdominal organs. Here you see the another is uterus pregnancy diagnosis. So pregnancy diagnosis normally at 45 days of age, normally pregnancy diagnosis can be done, but live or dead fetus can be even diagnosed by ultrasonography. If you see this one, the oval red circle, if you see the backbone is straight, if the backbone of the fetus is straight, when the backbone in an X-ray of the fetus is straight, it indicates that the fetus is live. But if you see this one, this backbone is curved. If this one backbone, when such type of X-rays, when the backbone is curved, this indicate that the fetus is dead. So this, you can see how means effectively we can use the X-ray for diagnosing the dead as well as the live fetuses as well. You can see the curved one. Even you can see in the uterus, there is a maceration is there, gas is present within the uterus. It means there is a gas within the uterus. It means the fetus is dead, and there can be infection or there is a gas within the. So this is how the X-ray will look like if there is a macerated, infected fetus is there. Here too, if you see the gas bubble around and the fetus indicates that it is emphysematous fetus is there. So they said, so uterine enlargement normally not visible, but if there is a pyometra is there, then it can look like a tubular structure which is ventral to the urinary bladder. So even you can highlight the uterus by compression technique. Compression means wooden, what we can do is, where there is a small wooden spoon can be compressed, caudal part of the abdomen can be compressed with the wooden, and then simultaneously take an X-ray. I'll show you the X-rays as well. Here is the pyometra. So you can see urinary bladder, upper, and these are the big loops. Big loops are visible. When these big loops are visible, same way these big loops will push even the small intestine cranially as well. So these are the loops of pyometra. So here you see these are loops are there, little bit doubtful, but what we can do is we can compress it with. You can see it is this part is compressed with the wooden spoon. Now the loops are clearly visible. So it means there is mild to moderate pyometra is there. First one was a severe pyometra, big pyometra, which is visible, but it is a mild to moderate pyometra. So which is further confirmed by using abdominal compression with wooden object, wooden spoon. So you can see that it can be wooden spoon can be compressed on the caudal side, and simultaneously X-ray can be taken. And then if there is a loops are distended, then it will be more clearly visible. If you see here, it is not the same dog when abdominal compression, the loops are clearly visible, more clear visible. So here you see at this point. So now in the end, when we conclude, so abdominal masses often cause displacement of other abdominal organs. This way can help to identify the origin of the mass in radiograph. So I already discussed in detail about the hepatomegaly, about the splenomegaly, about the kidney enlargement, about the prostate enlargement. It means they are going to displace the organ which are in relation or in approximation to these organs. It means in addition to these organs, we have to see the position of other organs as well. So this is so assessment of gastric axis help in diagnosis of liver enlargement. Location of small intestines help in diagnosis of splenomegaly and kidney enlargement. So VD in VD view. So this is the normal parameters 2.5 to 3.5 L2 length. This is a VD view, and CATS 2.5 to 3 times L2 length is the normal size of the kidneys. So prostate should not exceed more than 70% of the diameter of the sacro. This is already I told you in detail. So start measuring the sacropubic diameter and start comparing it with the prostate gland, whether it is enlarged or within less than 70%. So that will help you to diagnose the prostate gland enlargement as well. So contrast radiography can help you diagnosis of the various anomalies of urinary bladder, which I already discussed about. Urinary bladder rupture is there, or there is some radiolucent stones, or even cystitis. You want to see the wall as well. Then these perifetal or infrafetal gas around the fetus, or excessively curved skeleton in uterus can indicate that fetal death is there. So that's all from my side. So thanks for listening. So it was a little bit exhaustive, but I think I was able to justify. It all depends upon how you take it. Thank you very much, sir.
Sir, more than 100 vets attended till this time. So this is a grand success of this big lecture. It is almost 2.5 hours. You are
2.5 hours, yes.
Continuously you are speaking, sir. Not even any event. Speakers take a lecture of 40-50 minutes, not more than 1 hour, and then they take a break of 15 minutes, and then another lecture is there. So this is a kind of marathon lecture you had, sir. But it was really much appreciated, sir. The topic was literally much unexplored. You really shared very deep and meaningful insights. So I think there should be some queries. Can we see the chat box, sir?
Some queries. Yeah, chat box. Mostly wonderful, explained, excellent speaker. Yes, let me see if there are any questions. These are all appreciations, sir. Thank you very much. Thanks to all for appreciation. So I want that you should start using these points, which practically points I told you in your practice. Then you will able to justify the problem. You can even discuss with the owners, and owner will be more happier that you are able to tell us a lot of things by looking into just X-rays. Can you? Huh?
There is one question: risk involved in IVP or contrast radiography?
Yeah, risk involved is definitely there if there is a reaction to that drug, because but the reaction to drug can happen to anyone. One thing is any drug, but what you have to have that the steroids and anti-inflammatory drugs like Avel at that time if there is some reaction is there, but those reactions are not fatal, but there can be mild reaction, some seizures can be there, or hypersalivation can be there. Sometimes some dogs, they vomit it out, but they can be managed easily. But those are not, but provided I told you there are few contraindications are there, which I already told you in the slide. So those contraindications means there is animal should not have a severe heart disease, like a heart failure should not be there. So these are the points which you have to have to look. Can you tell us the quantity of air to be injected in contrast? Yes, it is 3 to 5 ml per kg. Okay. So wonderful session. Thank you very much. IVP and sedation required. Yes, very good question, which I missed. Yes. If you want to, there are two techniques are there for IVP. Because had I gone for those, it would have been quite longer than that. 3 hours lecture should have been there. So IVP, there are two types are there. Either you can go for bolus technique or you can go for CRI. Okay. If you go for CRI, then you have to go for sedation. But if you want to go for bolus technique, means immediately the dose is given as a bolus, then there is no need for sedation provided the animal is cooperative. If animal is not cooperative, then sedation has to be given, and it can be given without any problem. So for sedation, I will not recommend that you should not go for espromazine. You should not use xylazine because they further decrease the blood pressure. Whatever the drugs they decrease the blood pressure should not be used in IVP. You can use diazepam ketamine combination if you want a little bit sedation as well. Okay. In case of radiolucent foreign body injection such as clots, sir, you have to listen my last webinar. So I already told you about the foreign bodies in the stomach as well as in the intestine, how to check in for the clot as well. So there is a detailed description is there in the previous my webinar. So you can check those ones as well. So if you still have a problem, then we can you can send me as a message as well. Then I can tell you as a personal message that if you want to go for foreign body injection diagnosis. Okay. Any other questions, sir?
No, sir. This was the last one, sir.
IVP dilute? No, there is no need to dilute it. If you want to go for CRI, yes, you then use CRI. But if you want to go for bolus, then you can give at a rate of 2 ml per kg. But there is no need for dilution. 2 ml ditrizoate. Ditrizoate. I'm again telling you, if you want to go for contrast, don't use barium sulfate. This is only for GIT. Go for ditrizoate, and if you want to go for cystography, go for ditrizoate. Never infuse any other contrast medium inside the urinary bladder, or you can infuse air as well as a negative contrast. So you can see, like last yesterday, we diagnosed a case with Dr. Sarojini from Mumbai using only the air, putting the air inside the urinary bladder as well, because she was not having a ditrizoate. So we were able to diagnose the prostate neoplasia as well as cystitis. Thank you very much for taking a wonderful series of lecture. Thank you. Okay. Thanks Oriheal as well for organizing.
Sir, radiographic representation of intussusception, someone is asking.
Sir, you have to look for the previous. I don't know why you are putting the question in this webinar,
Yeah,
but
it has
already
been
I discussed
actually
in detail in previous webinar as well.
Yes, for abdominal, there was one more last lecture, and that is available on the YouTube. That is available on the YouTube. You can refer to that. Right, sir. I think it's all. IVP, any reaction, sir? Have you seen any reaction?
IVP reaction, just mild salivation and sometimes vomiting is there. Vomiting can be there. Or okay, so but that's why you have to have the steroid along with it. You have to even what you can do is before giving ditrizoate or urographine, we call it as a contrast medium, which is available in the market in the name of urographine. Before giving urographine, you infuse AVAL as well as steroid, so that the chances of a reaction that lowers.
Right, sir. So I think it's all over, sir. Thank you so much. So on behalf of the entire Oriheal Life Sciences team and all the attending veterinarians from across India, we extend our sincere gratitude to Dr. Arun Anand, Professor and Head Garvasu, Ludhiana, for delivering a highly insightful and enriching session on radiographic evaluation of abdominal organs in small animals. this Sunday afternoon, normally it's a very busy Sunday afternoon because all of the vets are busy in doing their either clinic or their home works. But still, your expertise, clarity, and practicality approach made this webinar immensely valuable for everyone, sir, who attended. We deeply appreciate your time and commitment to advancing veterinary knowledge in India, and always appreciate your enthusiasm, sir. You're always enthusiastic in teaching and always ready to talk about
Thank you very much.
anything you know. Yes, sir.
Yeah, thank you. So nice, sir. So nice for the kind words. But my idea is that we should give a good services to our clients.
Yes, sir. Yes, sir. So with that, sir, thank you very much once again, and we will be waiting for you for the next webinar, sir. Thank you, sir.
Thank you. So nice. Thank you.
Okay, sir. Have a wonderful evening.
Most trusted pharmaceutical company for companion animals of the year goes to Oriheal Lifesciences Private Limited, Dr. Vishal Sharma from Oriheal Lifesciences Private Limited.